Hello everyone. Once again, welcome to our MRSOG 3 ADC. And so this is the second case from the gynecology module. And I already have given you the introduction about the gynecology module. So now straight away, I'll be going through the station. So this is the endometriosis, which is very important. Endometriosis, they can ask they can ask you, it can come as a severe dysmenorrhea, congestive dysmenorrhea. So then you need to tell about the management options, and also sometimes laparoscopic diagnosis, you may have to go for that, minimal mild, and also sometimes moderate endometriosis where they will have pain, and but cyst will not be big cyst, it will be less than 3 centimeters where you may have to go for the medical management, you can go. And third thing is a huge cyst. In this case, in this case we have got huge cyst. So that is one thing, one aspect about endometriosis, where you need to discuss with the patient about the management options. Always management options in endometriosis is very important. Second thing, depending upon the age, if it is one woman who has come to the family, the treatment is very easy. But if the woman want to plan pregnancy, like in this case, then you will have problem, because you cannot give hormones, which is one of the mainstay of this endometriosis, because that will postpone their pregnancy. So you have to balance. Then so it can come as an infertility with the subfertility, the endometriosis with subfertility, or endometriosis in a very young girl with dysmenorrhea, or it can come as in an elderly age near menopause. So anything they can ask. And size of the cyst also you need to know. So we better to follow the NICE guidelines. Always follow the NICE guideline. And so then there is extra guideline also, but because it's RCOG, you go through the NICE guideline. Now coming to the case scenario, this is a simulated patient task, and then you are asked to assess this. You'll be assessed in the following, like same like any other station. Information gathering, they'll see how you are taking the information. Targeted history, communication with the patient. That means you are explaining the patient, how you are taking the history from the patient, and also in the communication, explaining the patient also. Patient safety, what all things which are important, that is about the name, age, and HS number. Just I'm stressing because you will not forget. So patient safety is confirming the name and addressing yourself, confirming the right patient, that you're talking to the right patient, and also confirming that the investigations belong to the same patient. That is always check the name and given in the case scenario, and also on the investigations, and also ask her the allergies, rule out allergies, and then management, whether always give the risk and benefits and consent. So everything, risk and benefits of everything, medical management, surgical management. Explain to her, see whether she's understanding, and then give her options, and then give her this thing to decide. Always you cannot decide, let her decide. And then so this is about the brief introduction. Now moving on to the station. You're an ST5 always you're an ST5 in a gynecology clinic. Remember where you are. And your next patient is Mrs. Lisa Thomas, 28 years, young, referred by her GP. Kindly see what he has written is, what he writes, usual letter will be there. GP letter also will be there on the exam. Kindly see Mrs. Lisa Thomas, that 29 years, working in a company. She complains of painful periods and want to plan pregnancy. So painful periods and pregnancy, these two things are there which you should address. She's trying since 1 year. She wants medical management and is not willing for surgery. So she wants medical, but you should think whether it is suitable for this patient or not. Now investigations are enclosed. Usually they will do the investigation, especially the scan. Serum AMH 2.5, because she's trying for pregnancy. They want to check the ovarian reserve, and that looks normal. CA125, 375. You need to know what all conditions where CA125 is raised. It's a tumor marker. And ultrasound scan done with the verbal consent. So it is confirmed. So Lisa Thomas, 28 years, it will be confirmed. Then uterus size they have given. Now bulky, it's bulky. Before that, you need to know what is the normal size. Otherwise, sometimes scan they will say it is bulky. Endometrium is thin. Right ovary has a cyst of 5 into 5 centimeters with ground glass appearance, that is typical of endometrioma, and left ovary has a cyst of 7 into 6 centimeters, ureter dilated, sigmoid colon seen adherent to the posterior surface of the uterus, impression bilateral endometriotic cyst with ureter and sigmoid colon involvement. That means it is extensive endometriosis. Now take targeted history, whatever is relevant to this case, and explain her investigations. You have to explain the scan report and also the and whatever concern she has, because she's planning for pregnancy, and pain also. These two are important things. Endometriosis, they have severe pain, their quality of life will be affected, and also subfertility will be affected. So these are her two main concerns. And how are you going to treat her? Because she says she wants medical. Now, how are you going to treat her? So now here you start this case. Introduce yourself. Hello, I'm Dr. Manjula, one of the doctors in the gynecology clinic. May I confirm your name and age, please? I'm Mrs. Lisa Thomas, doctor. I'm 28. How may I address you? You can call me Lisa, doctor. So, Liz, that is the introduction is over. So, I see now you start the agenda. I see from your notes, Lisa, I see from your notes that you have some pain during periods. You're having, you're suffering from pain during periods, and also sometimes they will give painful sex also, but if it is not there, don't say. So I see that you're having painful periods, and also I see that you're plan to have a kid. Am I correct? Yes, doctor. I'm having severe pain, and I want to have a baby also. So any other concern? Do you have any other concern? Now, otherwise later on you can ask. Now, so this is what she says, and so then you say, now, can you tell me more about you? Because I need to get some details from you. Lisa, I want to get some details from you so that it will help in our management plan. Can you tell me more about your concern, more about your problem, or more about your pain? Then she will say, doctor, I'm having severe pain. I'm suffering from severe pain from some years. And then, so it is really affecting me very badly, doctor. I'm not able to work also properly. Now, can you tell me when, since how long? I think since 5-6 years, doctor. Then, where is the pain? Exactly where do you feel? When? Where? She will say lower tongue, lower abdomen, yeah, right and left side, and both sides they will have severe lower abdominal pain. And so that then, can you tell me how severe when you get the pain? Severe, how severe it is. See, like suppose I give you the pain score of 0 to 10. How will you score your pain? Doctor, when I get pain, it is around 5 to 6, doctor. Then you say, what time you get the pain? When do you feel the pain? Is it related to your periods? Or it is not related to periods? Or it is related to both periods and also in between? So you have to specifically ask. So she will say, doctor, it starts before I get the periods. It was 3-4 days before, few days before it starts, and it remains throughout the period, and it is subsides after the period stops and bleeding stop. It will slowly subside, doctor. That means it is a very important typical feature of endometriosis, that is before, during, and after. But this is congestive dysmenorrhea, typical of endometriosis. Other pain, what I want to tell you is, this is for you, I am explaining. If it is a spasmodic dysmenorrhea, primary, then it will be starting with the time of with the period, just one day before periods or with the period, and then by second or third day it will fade, it will subside. So that is once the menstrual flow properly starts, it will subside. So that is why the pain is typical of endometriosis. Now, it is you have asked the pain, the quality of the pain, the type of pain, everything you have asked. So it is related to. Do you then? So she says that during periods and also after periods also it remains, then slowly it subsides, doctor. Have you taken any treatment for that? Have you consulted anyone and have you taken treatment? So, doctor, whenever I consulted, they told me to take pain for the tablet for the pain. They told me to take pain relief medications, doctor. They gave me. Then, okay, I would like to ask few personal questions. They may be intrusive. Can I ask? Signpost always for the sexual history. Then, what? Yes, doctor. What about your sexual life? Are you sexually active? Anyway, here it is not relevant, this question. Why? Because she's trying for pregnancy. So don't ask that. Otherwise, you have to. So then you say, then she will say, yes, doctor, we are trying for, yeah. Can you tell me more about it, about the pain when you say that you have pain during intercourse? Well, how is it pain? It is at the starting, that's superficial. It's the starting of the intercourse on deep penetration. When do you feel? Then she says whatever she says, she will you just note down. Then so that is about the dysmenorrhea. So dyspareunia. So dysmenorrhea you asked, dyspareunia is over. Now you want to rule out about other. And do you have pain at any other time also other than the period? Any other time? No, doctor. Sometimes they'll have chronic pelvic pain. So no, doctor. Then any pain related to, is it affecting your bowel movements? bowel opening. Is it affecting bowel opening during periods? Or sometimes there can be blood in the motion, in the stool when during periods. So that you have to find out. And any blood, do you have any problem with the waterworks? Do you see any pain of bleeding in the urine when you get periods? So this is so these are the things which you should ask related to the bowel bladder, because they're closely related to each other, these organs. And you have seen the scan report also that ureter is involved, bowel is involved. So pain on bowel opening and pain on emptying bladder, blood also in the stool, blood in the urine. So now, is it affecting your quality of life? Naturally, it will affect. Yes, doctor, I'm really frequently taking sick leave from the office. I'm so sorry. I'm so sorry to see your difficult situation. Lisa, we are here to help and support you. Then, about coming to the other thing, Lisa, I see from your notes that you're trying to have a kid, trying to have a baby or trying for a pregnancy since 1 year. So, have you consulted anyone? And did you consult anyone? Or have you taken any treatment? So she will say yes or no. Yes, or we tried naturally, doctor, but nothing has happened. We have not taken any treatment. Or if she has taken, she will say. So this is about the third thing. So in this thing, you have asked about the details about the period pain, that is dysmenorrhea, and also dyspareunia, and also infertility, subfertility. So these things you have covered. Now other organs also you have deep infiltrating, and this is deep infiltrating endometriosis. Why? Because bowel and ureter is involved. So you have asked the symptoms of those also. Now, don't ask anything, cough and shortness of breath and this and that. Don't ask, because it's related targeted history only you say. Because there can be lung secondaries, there can be secondaries anywhere. So you cannot ask each and every symptom of every organ. Don't ask. So now gynec history. Coming to the gynec history, because always gynec history is first after information gathering, then obstetric. So what about? Can you tell me more about your periods? Are they regular? Do you get periods regularly? And when was your last period? LMP is very important. So she says recently 1 or 2 weeks, within 1 month, 4 weeks. Yes. If suppose it is delayed, then you say, have you done any pregnancy test? So then that's this important safety point of view. Then have you used any contraceptives before? Because she's trying for pregnancy. So one thing you can say is, since how long you're staying together and since how long you're trying for pregnancy. Suppose she's staying together 1 year and trying for pregnancy 1 year, no need of asking any contraceptives. But if they're staying together for 3-4 years and trying for pregnancy since 1 year, you need to ask about the contraception. Then, any pregnancies, have you been pregnant before? Any pregnancies before? Then, coming to the medical history, are you on any regular medication? Instead of asking, do you have diabetes? Do you have hypertension? Instead of asking each and everything, you just say, are you on long-term medication? Okay. Any allergies? Do you have any allergies? What about your blood group? Do you have any idea? Okay. Now coming to the in the sexual history, once again you have, and let me tell you one point, that is few things you have to, in the sexual history you have to ask about few things. So so one thing is, since how long you're staying together and since how long you're trying. This is one thing. Have you used any contraceptives over? Then how about how frequently, because she's trying for pregnancy, 3-4 things you should ask. How frequently you have intercourse? How frequently? Usually 3 times in a week is what we expect normally. So frequency of intercourse, and any difficulty do you face, any you or your partner, do you face any difficulties? Because she can face vaginismus or dysmenorrhea, he can face erectile dysfunction and premature ejaculation or pain. Both of them can have pain. So these are the things which you, and anytime have you had any infection, sexually shared infection, like pain in the tummy or fever or any discharge, abnormal discharge from down below? So these are the things which you should ask in the sexual history after the gynec history. Are you, since how long you're staying together? Since how long you're trying? Do you have any problem? Are you having used any contraceptives? How frequently you have the intercourse? And any difficulty, whether she is facing any difficulty like vaginismus or dyspareunia, or whether he is facing her partner like impotence, erectile dysfunction, ejaculation, premature ejaculation. And anytime sexually shared infection, anytime they had any sexually shared infection, you say fever, like fever, because they know what is sexual, they don't know. So you say specifically fever, pain in the abdomen, tummy, and discharge down below. If they say yes, if she says yes, have you taken any treatment? And like that you should ask. And then, so now these are the things which you have to ask in the sexual history. Then coming to the obstetric history, then medical history is over, then surgical history. Have you undergone any operations in the past? And in the family history, do you have any family history of any concern, any similar condition? That means similar endometriosis in the family, and sometimes they give positive family history. And how about your personal habits? Do you smoke, take alcohol, and pardon me for asking, the recreational drugs? And how about your BMI, body mass index, BMI, and or height weight ratio? You can ask, how is the support at home? She needs very good support at home because she is suffering with the severe pain. So how is the support at home? Do you get a good support from your family members, your partner and family? And then what do you do for, she's already what are you working in a company? So you know her that she's working, and you no need to ask again. Is it affecting your mental health? That is, do you feel down and depressed? Sometimes they say, should I arrange a counselor for you? Because it can affect the severe endometriosis will affect the quality of life and also mental status also. Then you can say, can I arrange a counselor for you? So this is about the information gathering. Would you like to add anything, Lisa? Would you like to add anything so that whatever she misses, you can note down? Then about the examination. Actually, you can say, can I examine? Because if the examination findings are not given, here scan findings are given. So examination findings are not given, you can go for an examination because you want to see with sometimes local nodules also will be there. Vaginal nodules can be there. Nodularity will be there in the pouch of the breast. So you say, can I examine you in the presence of chaperone? I would like to examine your tummy because the cysts can be palpable also. They'll be tender. And I also down below. I would like to see down below. You have to say why you want to examine. To see whether there are any small nodules. So I would like to examine. So then, yes, doctor, she will say, then okay. So after the examination, then you say, now coming to the discussion. Now that is applied clinical knowledge. Now, Lisa, let me explain to you about your condition. So I have your reports with reports with me, the scan report and the blood report. Do you have any idea about your scan report? Did anyone explain to you about your scan report? Always make sure the scan reports are that whether she has any idea about or not. So, no, doctor, I don't know. I don't know anything. Nobody told me, sir. So, okay. I shall explain to you. And I will address all your concerns. See, the scan report is here and your blood reports. I have confirmed your name, age, and NHS number on all the reports, so that no need to repeat for everything. Now, let me draw and show. Here again, picture diagram. So, I have confirmed name and it shows that you have a condition called endometriosis, endometriotic cyst. So, what is it, doctor? I'm going to explain to you. So let me draw and show. Now you can explain clearly. Draw a picture, draw a diagram always, and say, see, this is the womb. This is the lining of the womb. This is little bigger than this womb is slightly bigger than the normal. Always explain to her because it's normal. If it is normal, you say normal. If they say it is bulky, you say it's slightly bigger than the normal. Then this is the lining. It is normal, and these are the two ovaries. They will understand what it is ovary means. So this is the right ovary, this is the left ovary, and so the right ovary, you see it has got a cyst. That is, it is a fluid filled sac. It is a sac with blood. So that is why it is looking hazy. It is ground glass appearance. This is 5 centimeters around. The left ovary also has a good cyst. It is around 7 centimeters. One measurement you can see. And it is also looking hazy. That is filled with the blood. And that is called, that's showing this appearance. Now, see, this is the ureter. That is a water pipe. It is coming from the kidney and it is entering the water bag. This is the water pipe. And that also is enlarged. It is big. It is dilated. Means they may not understand. It is bigger, enlarged. And see, this is the bowel that is behind. This is behind the womb. This is the bowel that's called sigmoid colon. It is it is stuck to the womb. So this condition we call it as endometriosis, with both the ovaries having cyst called endometriotic cyst in the medical terms. So am I clear? Lisa? So whatever you're explaining, that's what you're asking. So this is, so how does it happen? What is it, doctor? Actually, what is this endometriosis, doctor? So now, see this endometriosis. This is the lining of the womb, which I have shown you. This lining of the womb, usually it is inside the womb, but sometimes it starts growing elsewhere, other places also in the tummy. It will grow in other places also, similar tissue. So that will be around the womb. It can be around the womb, in the ovaries, or on the lining of the tummy. Anywhere it can grow, any part of the body it can go and implant and grow. So in then every period, whenever you get monthly periods, when because of the hormonal this thing effect, this tissue also, which is outside the womb also, will start responding. So it will enlarge, it will bleed, it start bleeding. Am I clear, Lisa? Yes, doctor. Then how this ovarian cyst formed? As yeah, I'm coming to that point. See, in the ovary also is having the lining, similar type of lining which womb has. That is so. Whenever the periods start, this starts growing inside the ovary. It also starts growing, and it forms a. It is get filled up with the blood every month. It also bleeds and get filled up with the blood because it is a closed structure. It becomes a mass. It becomes a mass that is called cyst. It forms a cyst. This condition is called endometriotic cyst. Got it? Am I clear? Yes. So this cyst becomes active every month. That is why it grows. And then now coming to this is called endometriotic cyst, which I told you. Now, other thing is these ovaries are good. One is 5 centimeters and one is 7 centimeters. And other things, what the other things which I want to tell you, this water pipe also is stuck here. And I told you, no. So this condition is we call it as advanced stage, severe. This is the severe condition where both bowel and water pipe and bowel got also involved. So this is about your phase one. So then coming to the blood report, which I want to tell you. See, one is the AMH. See, this is the AMH. You show with your finger on the paper. This say that this is the AMH and this is 2.5. It is normal. That means your ovaries are having enough of eggs. So the second thing is this is tumor marker which we do in the tumor protein. It is a tumor protein that is CA125. It is higher than it is normal. It is less than 35, but it's higher than normal. But doesn't matter. It can raise. It will be raised in many conditions, and one of it is endometriosis. So it is a non-specific. It is not very specific to the endometriosis. It is non-specific. So Lisa, now. Doctor, then is there any treatment for I don't want to go for any surgery? Is there any treatment for that? Yes, if you permit me, I will explain to you your management. Let me explain to you. I'll take you through the options, and you can decide what after my explaining you can decide. I'll give you risk and benefit of each option. Okay, Lisa. Now, coming first thing which I want to mention, stress is lifestyle modification. Lisa, you need to, let me tell you a word about the lifestyle modification. Sometimes they say it will prevent also. See, that is, we encourage diet and exercise program. That is, exercise is very important. So do some practice. We'll refer you to the diet exercise program. Start doing some exercise. And also, if she takes alcohol, reduce the alcohol. You say, so depending from the history what you got. If she takes alcohol, ask her to reduce minimum, to take minimum, and then healthy diet and exercise. This is what you have to tell her. Now, this is about lifestyle. The other thing is about the medical. We have two type of treatments, Lisa. One is medical and one is operation. That is surgery. I see that you are refusing. You're not willing for medical management, isn't it? Yes, doctor. Can may I know the reason? Always say anything if they are not willing. You say, may I know the reason? Then she will say, I'm scared of the surgery, doctor. Whatever. Mostly they will say surgery. Or my ovaries, then I will not have any babies. Once you do the surgery, if you remove my ovaries, I will not have any baby. So, no, I will address all your concerns. So, let me explain to you. Coming to the medical management, let me tell you, we'll give you painkillers because you're having severe pain. We'll give you painkillers. So there's you can whenever you get pain, you can take and they have not much side effects. If at all they take, they may cause some tummy upset in the tummy. Sometimes they can be allergies. If you don't have allergies, we'll give you. Okay, Lisa. Then second thing is we can give some hormones. We can also give some hormones that is which are very good. They reduce the pain and they reduce endometriosis also. But these like there are hormones like progesterone and estrogen, and so then we have various options like combined hormonal pills. We combine estrogen and progesterones. They're available as copper coil, hormone coil injections. They're available as tablets. There are so various forms they are available. This estrogen, progesterone, and some injections, special injections called gonadotropin release hormones and hormone coil. But listen, let me tell you, these are not suitable for you. You know why? Because they will not allow egg release to happen. If suppose we give you hormones, they will stop the egg release. And because you are planning pregnancy, we cannot give you, Lisa. So medical treatment is not suitable for you actually. Because you're planning pregnancy, it is. And second thing which I want to tell you, the cyst are quite big. The big cyst. So it's always better to go for surgery, remove the cyst. This is better for you. Shall I explain the surgery also? So you have to explain surgery also. So yes, doctor. Then you decide whatever you want. Okay. Now, Lisa, coming to the surgery, this is done by because the cyst are quite good size, and also the ureter is involved, the water pipe is involved, the bowel is involved. They are all stuck together. It's a severe case. Your case is a severe case. So your case is you'll be under a special team of doctors. Listen, that is multidisciplinary team. That is it includes our consultant gynecologist, bowel surgeon. Then we need to the kidney specialist or the urology also. We will involve him. We need to have radiology, imaging doctor also. Sometimes because we may have to go for special imaging, and then it is and senior, I mean specialist nurse. Then also counseling, also counselor also we will involve. Then this surgery is done. Let me tell you, it is done in a tertiary higher centers with expertise because it is a complicated case. It is done by expertise only. And then, so before doing surgery, we will do a special imaging called MRI to see how much the organs are clumped together, attached to, fixed together. So we will advise in imaging. That's called MRI. So am I clear so far? Yes, doctor. So I know you don't want medical treatment, but let me tell you, surgery is a golden option. It's a standard, gold standard for this case. And we can go for there are two methods. We can go for keyhole surgery or we can go for open method. So shall I explain to you? Yes, doctor. So keyhole surgery is what we prefer because there are 3 to 4 small cuts are given on the tummy and we look inside and passing the telescope, we look inside everything and treat it. Yeah, so that is and the advantages are it is a short hospital stay. You can so you can be discharged very fast and you can do your normal activities soon also. Your recovery also very fast. Okay, but let me tell you, sometimes it may not be possible, Lisa. Sometimes it may not be possible to do keyhole surgery. In that case, we may have to go for open cut, where a larger cut is given on the tummy. So am I clear? So like that you can show on the diagram also. So you can show on the picture that these are the small cuts and this is the bigger cut. Now we are either it is keyhole surgery or it is open surgery. There are two types of methods how to manage this cyst. Shall I explain to you in detail both? Yes, doctor. So one is in any of these case, any open cut or this thing, what we can do is we can completely, one method is where we completely remove the cyst. We completely totally remove the cyst and clear all the surrounding areas. That is the bowel we separate, bladder we separate, everything, and that water pipe we separate and make everything clear. And then this is called stripping and excision of the cyst wall. Stripping and excision of the cyst wall. That is we are removing total cyst and clearing everything. And all the which are stuck together, everything will repair. I mean, clear them, separate them. So, but this is in this more damage. Let me tell you, the disadvantage is that is the risk is it will cause more damage to the ovary, the underlying ovarian healthy ovarian tissue. That is the ovary with healthy follicles that may be lost during surgery. But the benefits are the endometriosis is cured. The chance of it coming back is less and the pain also will be very less. You'll be relieved of pain. The second option, shall I tell you the second option? Yes, doctor. We can just, instead of removing the cyst, we can give a cut on the cyst and then open it and drain it. We can open and drain it. So then finish and clear the cyst. So this is called drainage. So in this is benefit is it causes less damage to the ovary. The ovarian reserve, the healthy tissue will not be damaged so much, and then ovarian reserve will not be affected. But the possibility of it can come back again. It can come back again. So these are the two choices we have, and whatever you wish. Whatever you wish, whatever you want us to do, we'll do. Whatever, and we'll support it. But let me tell you, there are risks and benefits of it. because it's a surgery, they can be, the benefits will be, you will get the pain relief, and you will have the chance of to become pregnant will improve. You can conceive yourself without any treatment, spot that is naturally, or sometimes may have to help you to conceive. That's medically assisted reproduction. So, what about the risk? Shall I tell you the risk? Yes, doctor. There can be bleeding, there can be infection, there can be the damage, injury to the other organs. So these can happen. But let me tell you, our team of doctors they are there to manage all this. So now this is about the whatever about the treatment I have explained to you. So and the other thing which I want to tell you is, because of this big surgery, there can be some scarring. So there can be so the your chances to become pregnant also can be affected. The tubes can be involved because of the scarring. So that also can happen. So now am I clear? So this is the information leaflet. This is about endometriosis, what we have discussed. You go through this, and then you'll have an idea. I will document whatever we have discussed. Okay, then I will give an appointment with my consultant. So you can discuss with your partner, and next visit when you come, you decide and tell us your option. And then other thing is, I'll connect you to the support group, Lisa, so that people who are like similar, with affected by similar condition, they are there, and you can get connected to them. And if you permit, I'll write back to your GP. Okay. So now, do you have any other concerns? So now that I have given you the medical management, because you're and the surgery, and because you are planning for pregnancy, what I feel is surgery is better than medical. You think about it, and surgery can can give you pain relief, and also your chances to become pregnant will increase. So, and any other concern? No, doctor. So this thank you for your time, Lisa.